Thanks, Adam. This is just the Opioid Addiction Treatment 101. So this is Introduction to Opiate Use Disorder. This will be a review for most of you. And so I'd like, if you could, for you to just bring up questions or comments all throughout the presentation and try to make it as interactive as possible. I don't have any disclosures, and what we're going to do basically is define opioids. We're going to review opioid intoxication, understand a little bit of the parameters of the opioid epidemic. We'll learn about some harms from opioids. We'll review the criteria for opioid use disorder, and we'll understand the role of primary care teams in addressing opioid use disorder. And then lastly, we'll spend a little bit of time confronting stigma. So basically, opioids refers to agents that bind to the body's opioid receptors. There's three opioid types of receptors in the body that have various effects. The natural opioids, the ones that are derived from the opium poppy, include morphine and codeine and opium. Hydrocodone will also be metabolized into opiate metabolites. And then there are synthetic, either partially or completely synthetic, and these are called opioids. So opioids is the blanket term that includes natural and synthetic members of the drug class. So the opioids are the semi-synthetic ones or the fully synthetic ones that you can see listed here. Now, all of these medications have potential for causing addiction. They also have these common effects that can be quite useful. For example, pain relief, like post-surgically or during surgery, cough suppression, constipation, sedation. These ones are not so useful effects: respiratory suppression, respiratory arrest, and death. These are the things that end up causing accidental overdose deaths. So here is our splash screen of what's an opioid and what's not an opioid. So that's sort of, it's like a thumbs up kind of thing if it's an opioid. So tramadol, opioid or not an opioid? Thumbs up, thumbs down, thumbs up. There's another thumbs down, thumbs. So technically speaking, tramadol is an opioid because it acts on the opioid receptors. It is an opioid receptor partial agonist. You would still call it an opioid since it interacts with the opioid receptors. Let's see here. Methamphetamine, opioid, not opioid. Thumbs down, yes. It's like, this feels like a gladiatorial match where you're like, thumbs up or thumbs down. This is good. Okay, yeah, methamphetamine, not an opioid. Let's see. Percocet, how about that one? Opioid, not an opioid. Thumbs up. Some very enthusiastic thumbs up. There's some Percocet lovers out there. Mushrooms, opioids, not opioids? Yeah, negative, right. So you all pretty clearly recognize the opioids versus not opioids. So they're very effective for acute pain. So they're great for inducing anesthesia, for maintaining anesthesia, for pain management after an acute injury while healing is taking place. You want to ensure functionality, the respiratory functionality or functionality of the body area that was operated upon. They're pretty limited in their effectiveness for chronic pain conditions. The absolute drop in the sort of pain amounts with a chronic opioid for many chronic pain conditions is very, very, very modest. And then there doesn't seem to be much of an improvement in functionality. So judicious use of opioids in an acute setting is a really helpful thing. Interestingly, when we look at sort of more long-term treatments, what we find is that healthcare personnel who are of a different cultural, racial background than their patients consistently underrate those patients' pain experiences versus subjective experiences. Whereas when the culture and racial orientation are in alignment, there is more accurate representation. And so this is an important part of opioid prescribing and treatment of pain, is to keep in mind that cultural barriers can create barriers in communication, accurate reception of communication about pain. So, opioid intoxication. What does somebody look like when they are intoxicated with opioids? So just go ahead and unmute and speak up. What does somebody look like when they're intoxicated?
Can they act it out?
Oh. Oh, Scott, we're catching a lot of background noise there. Go ahead, Casey.
I say they look very sleepy. They have very small pupils. I've seen people like start nodding out, or they're like trying to keep themselves awake, kind of thing.
Yep.
This is the motion.
The nodding. It's the
Yeah.
nodding. Yeah. We'll take charades as well. Anybody else? Any other experiences with people who are intoxicated with opiates?
Well, respiratory depression, of course.
Right.
I mean,
they may stop breathing.
Are very slow and shallow and.
Mm-hmm. Yeah, they may even start to look cyanotic or blue.
Right.
Yeah. Yep. And then sometimes you see people when they are intoxicated on opioids, they get euphoric. We did a Suboxone induction on a patient in our clinic this past week, and the patient took their first dose of Suboxone and started singing "I Am Woman, Hear Me Roar," and we guessed that this is probably an adequate dose of Suboxone for this patient, and that she probably was not taking as much opioids on the outpatient side or outside the clinic as she was reporting. All right, yeah. So drowsiness, slowed speech, confusion, so this euphoric high, and then pinpoint pupils. Yep. Okay, what major problems do opioids cause? Anybody? Just go to unmute and speak to the major problems.
Constipation is a big one.
Yes.
Huge.
Yes. And it gets bigger with time.
Yes.
Yes.
It does.
Anybody else?
Physical dependence and tolerance.
Yep. Tolerance and withdrawal. So what they call physical dependence. Casey?
That decreased ability to tolerate pain. So there's the strong drive, the cravings that they have to get it, and if they're in pain, it's even stronger.
Sure. Yeah, so pain can interact with their withdrawal symptoms to drive their craving or drive their use. And there is such a thing as opioid-induced hyperalgesia, where there's pain gets worse over time despite escalating doses of opioids. What else? What other problems do opioids cause? Go ahead, Merviana.
Eventual loss of jobs.
Yeah, as people start to replace their normal activities with activities that are necessary for them to acquire, use, and recover from the substance. And so this could not only be the reduction of the sort of prosocial behaviors, but introduction of some behaviors that could be potentially harmful for them. For example, theft or sex work in order to support the opioid use habit. Yeah. Other harms, major problems?
I've seen people, earlier they've talked about increase in mental health symptoms, so anxiety, depression, or because of how they get their opiate, that they're going out and putting themselves in situations that may lead to traumatic situations or traumatic consequences.
Yeah, use in dangerous situations, or use around dangerous situations. So obviously the worst outcome is overdose and death from opiates. Addiction and opioid use disorder can be used interchangeably. And then we talked about some of the other problems. Some of the other problems that come up are, bloodborne infections, hepatitis C, HIV, endocarditis, abscesses, bone infections, and so on that can occur with injection use of opiates in particular. So why have opioids become such a big problem in the United States? Well, the United States consumes much more opioids than any other country. There's like a insatiable appetite for opioids in the United States. In the 1990s, the Joint Commission designated pain as the fifth vital sign and was pushing providers to eliminate pain as part of effective treatment. Now, I think this is a useful thing. Pain being the fifth vital sign is a very useful thing in terms of picking up on acute injuries, picking up on things that may require additional intervention. And also, it's a very, very helpful thing when you have somebody with, say, for example, cancer, and your goal still in cancer care is to minimize pain as much as possible. Now, however, this push to eliminate pain in everybody was sort of dovetailed with pharmaceutical company promotion of opioids as a means in which to do this, which led to some overprescribing behaviors and even some maladaptive prescribing behaviors, such as some of the pill mills, for example, like the ones that existed in Florida. And then increased diversion, widespread non-medical use. And then once somebody starts to use opioids, it can be quite expensive. And then if they can't get it medically, then heroin becomes a less expensive alternative for them. This is a chart showing kilograms of opioids sold commercially in the United States from 1999 to 2010. You can see this increase. This is per 10,000 people. So 7 kilograms of opioids per 10,000 people in 2010. This dovetails, it correlates with deaths due to opioid overdose and also admissions for opioid abuse treatment. Here are the age-adjusted opioid overdose death rates related to both prescription opioids and heroin. And you can see these sharp increases over the course of the past 15 years. These are trends in non-medical use of pain relievers. So this is by age. This brown one here is 18 to 25. The red one here is 12 to 17. Black one here is 12 or older. And then the little pentagon-shaped one is 26 or older. And you can see there's some decrease in non-medical use of pain relievers over time. So that's a lucky trend. Now, drug overdose deaths cause more deaths in the United States than motor vehicle accident deaths or firearms deaths. So it is estimated that 91 people in the United States die every day from an opioid overdose. So this is one of the reasons why they call it an epidemic, opioid overdose epidemic. Now, part of this epidemic in terms of opioid overdose deaths is due to some of the synthetic opioids that have started making their way into opioids that are found on the street. So fentanyl, highly potent synthetic opioid. You all who are prescribers know that the dosing of fentanyl is in the microgram range, whereas the dosing of other opioids is usually in the milligram range. So this tells you that it's quite a bit more potent than other opioids. So estimated to be 100 times more potent than heroin. It's easy to manufacture. It can be cut into heroin and sold as heroin. And there's been a rise of overdoses. For example, fentanyl accounts for 2/3 of overdoses in Massachusetts now. I've just started seeing in my patients here in New Mexico an increase in fentanyl-positive urines amongst my patients who inject opioids. And it can be difficult to reverse fentanyl because of potency. Now, interestingly, things like fentanyl and the synthetic opioids like oxycodone, methadone, buprenorphine, these won't be picked up on a normal drug screen. The normal drug screens typically only test for opiates, so that will pick up like morphine, codeine, heroin, and oxycodone metabolites. So if you're curious about whether or not somebody is using fentanyl, you have to test independently for fentanyl metabolites. So it would be under the opioid screen, or sometimes there are some urine drug screens that include fentanyl separately. Methadone always has to be tested separately, and buprenorphine always has to be tested separately. All right, so what is opioid use disorder? Put simply, it's opioid addiction. The American Society of Addiction Medicine describes addiction as a primary, chronic, and relapsing brain disease characterized by an individual pathologically pursuing reward and/or relief by substance use and other behaviors. So it's interesting because addiction is a brain disease that's developed in the context of a use behavior. Once somebody has the addictive disorder, it implies that their brain has shifted into these sort of addictive or addiction-related functionality. It's not to say that people who develop an addiction disorder have abnormal brains before they develop their addiction disorder. They develop it as a result of the addiction. But then the changes in brain functionality persist beyond the addiction disorder itself. Physical dependence on opioids is not the same as opioid use disorder. Somebody explain what they're trying to get at by this, somebody on the network. What do they mean by this?
Patients can be using prescribed opiate medications and become physically dependent. They get the withdrawal and the tolerance built up, but they're not using it in an addictive way to get that relief or euphoria from it. Exactly.
And this is why tolerance and withdrawal, if they're the only two criteria, it doesn't count towards opioid use disorder if you're considering prescribed opioid treatment. So this is the diagnostic criteria for opiate use disorder from the DSM-5, and 2 or more of these criteria equals an opioid use disorder. And so all the things that we were talking about before in terms of problems from opioids, people using larger amounts or longer than intended, this much time spent using actually includes a lot of time being spent either acquiring, using, or recovering from the effects of the opioid. So it's not just a lot of time spent using, it's all the lead up and the tail end afterwards. Activities are given up in order to use, and then furthermore, there can be hazardous use. So activities given up and then hazardous use like using in dangerous situations or engaging in dangerous activities in order to support the use. Things get neglected. People start to have physical or psychological problems, start to have erosion in their social and interpersonal lives. And then craving was something that was added newly to the DSM-5. So any 2 of these will equal opioid use disorder, except if you're thinking about it in terms of prescribed opiate treatment. If there's only withdrawal and tolerance, then it doesn't count. All right, here's some examples, and we're going to see how we decide whether or not somebody has opioid use disorder. So this is an example of a 37-year-old guy who prescribed opioids for pain control after a motorcycle accident, multiple surgeries, receiving prescriptions for opioids for many months. He tells you that the opioid analgesic doses that he has been prescribed are no longer controlling his pain. He is asking for a higher dose or a more potent formulation. Does this person have opioid use disorder from what we see here? You see somebody being prescribed opioids, and it looks like he's building a, what do you call this when somebody, the same amount is not giving him the same effect? What's that called, Murviana?
Tolerance.
Yeah, Murviana and Laurel, tied for tolerance. Yep, that's tolerance. And so what else would we need to know whether or not he has an opioid use disorder?
Has he been taking his medication as prescribed, or has he been taking more than he was prescribed?
Right. Is he like taking more amounts, say, to not only to relieve pain, but to feel a sense of euphoria and then running out? Yeah. What else would we need to know? Or what else present in this context would say this is probably an opioid use disorder? How about if the urine drug screen came up? Go ahead, Murviana.
Well, I was just going to say, is he going to other providers for the medication?
Mm-hmm. Yeah, say he's doing something illegal in order to acquire more opioids. What about if he says that he says to you that he's starting to crave the opioids? That sort of be indicative of a mild opioid use disorder? Really starting to crave these opioids. They make my life feel rosy for the next 4 hours after I take them. Maybe.
Yeah, absolutely. I mean, that's one of the things when people tell me that's one of my first cues. And in fact, I'll even write it in one of my kind of sticky notes in my EMR that patients don't have access to, is when they say, yeah, I take that, it really makes me feel good. It's like, warning, don't really think about whether or not opioids are a good choice, when someone's in for an acute pain kind of syndrome, for the future. That for me is a huge point.
Good. That's a good point, Laurel, and it certainly is a sort of a warning sign that I would also say that that sense of euphoria it becomes craving when they say that made me feel really good and I'm really looking forward to my next one. And that sense of euphoria, there are some people who get a sense of euphoria and they're like, I was disturbed by the sense of euphoria because it might mean that I'm becoming addicted and I don't want to become addicted. So the euphoria itself doesn't necessarily imply the opioid use disorder, but what how they talk about the euphoria and how they relate to it could pertain to whether they have the disorder. All right, this person, a 52-year-old woman, prescribed 180 morphine milliequivalents per day. That's what MME stands for. It's when you convert a dose to morphine equivalent doses. So prescribe 180 morphine milliequivalents per day for chronic pain, for inflammatory bowel syndrome. Patient's former physician has left her practice and she is transferring to you for care. You note that the prescription monitoring program shows that she has received additional opioids in 2 different emergency department visits the last month. The front desk staff tell you that the patient has recently lost her job and is getting divorced. So how would you decide if she has an opioid use disorder?
My first thing would be trying to figure out what's going on with those 2 emergency room visits. Was that because she ran out of the medication, because the tolerance was higher than the medication could address, or kind of what was going on there?
Mm-hmm. Mm-hmm. Yeah, what other things?
I agree. And as well with that, if you have a controlled substance agreement, which we do, that would be, a clear violation. And then I think just going farther with, more of the questions about, so tell me more about kind of what's happening and what's, tell me, just getting, if this is the first time you're meeting with them, I'm not sure you want to set up an adversarial relationship, but you certainly want to gather more information about, what's going on and the use over time and all of that kind of information, and all the stress in her life and how is she using the medication, how she's managing her stress and all of that.
Sure. Yeah. Yeah, and Misty Long had sent a text just indicating that she would just go through the criteria of the opiate use disorder, and that's frequently a really good way of doing it. And if you show, show curiosity and empathy when you're asking those questions, and say, for example, if you utilize a normalizing stance, like many people who take opioids for a long period of time for pain, they can start noticing themselves like craving their next dose, or they can start noticing that they're starting to have problems because of the opioids. And are those things happening to you? I can go over pretty well. Merviana, you were going to say something? You're muted, Merviana.
Sorry, it's along the same vein of what you were saying, using that sort of that checklist.
Yeah.
She's lost her job and is having some social problems because she's getting divorced, and trying to evaluate that further with her.
Right, and you have to wonder, are these things as a result of her opioid use?
Right.
Or is the opioid increased use as a result of these stresses?
Right.
Yeah. All right, next person. 19-year-old woman comes in with a large abscess on her arm. She has track marks on both her arms and hands and acknowledges injecting heroin several times per day. She has been trading sex for drugs and was recently released from jail. What's the diagnosis and what kind of physical and emotional care may be needed? And how would you talk with her about her drug use? What's your diagnosis here? Right.
She needs an incision and drainage of the abscess on her arm. That's one of the diagnoses.
Mm-hmm. Mm-hmm.
I think the heroin several times a day would fall under opiate dependence or opiate use disorder. She needs a bunch of blood tests, and then finding out more about the physical and emotional problems that are going on with her. But I would put the priority on the abscess, I guess.
Sure, yeah. And this criteria here of trading sex for drugs, so this is like use, this falls under use in dangerous situations. And these track marks and large abscess, this falls under the category of continued use despite adverse consequences for the opioids. Now, interestingly enough, the injecting heroin several times per day, just in and of itself, would not meet criteria for opioid use disorder. If it was just somebody injecting heroin multiple times a day. Now, if it's somebody injecting heroin multiple times a day because they've built dependence and they have withdrawal, that would be something that would meet the criteria for the use disorder.
Would that also count for the spending a lot of time on activities related to the opiate use? Like I have to shoot up, I have to go get it, shoot up, then I'm high, withdrawal, then shoot up again, and
well, interestingly, there are some European countries, I think Switzerland in particular, that will actually use heroin to treat heroin dependence. And people will come into the shooting galleries and they will shoot multiple times a day. And so under that circumstance, like if they're just doing, it's like kind of taking their lunch break, their breakfast break, their lunch break, and their dinner break, but they're not having any problematic behaviors related to it, it wouldn't be necessarily an opioid use disorder. But in our context, since we don't use heroin to treat heroin, it would probably imply that she's spending a lot of time acquiring and recovering. So how would you talk with her about her drug use? You would say, your drug use means you're a really bad person. And you need to stop that right now, stop all that bad behavior. How would you introduce the diagnosis to her?
Make sure you call it drug abuse so she feels worse about it.
Oh, right, sure, yeah.
Just kidding. I would just acknowledge that that's, by what you're seeing in your exam room, tells a little bit of her story, and that you want to know the story from her perspective.
Yeah.
Because I think that person came for help, most likely. So gotta start there.
Have you ever used this sort of like, I'm really worried about your health. I'm really concerned about you. Has used that approach, or the approach of, Misty says, it looks like your substance use is causing you some issues. Can I help you with this? Yes. Very solicitous, Misty. Yeah, so a really gentle kind of approach. Oh, there's more. Oh, smiley face. Okay, so this is the slide that's getting an ounce of prevention being worth a pound of cure. So this is a slide that's suggesting to primary care teams to approach the treatment of pain in more conservative fashions. And this is based off of CDC guidelines in 2016. So the three principles of opioid prescribing per the CDC are, number one, try to use non-opioid therapies. So for example, non-pharmacologic therapies whenever that's relevant, and non-opioid pharmacologic therapies whenever that's relevant. Try to establish and measure goals for pain and function. And don't routinely use opioids to treat chronic pain. There are a number of treatments that are non-pharmacologic that can improve function, that don't have much of an impact on the pain, but people's functioning improves and they start to actually feel better about themselves and their lives. So for example, one is called acceptance and commitment therapy. It can improve functionality. If you're going to prescribe an opioid, start low and go slow. Start with the lowest possible effective dose. Start with immediate release. Only prescribe the amount needed for the expected duration of pain. So for example, post-surgically, however long you expect the healing process to take place. And then track the effects of it and taper and discontinue if there are no improvements or risks of harms outweigh the benefits. One of the things that happens here is that care providers are busy. Patients can be quite attached to their opioids, and this can lead to a situation in which there's a potential for conflict, and then also a potential for a provider to want to avoid that conflict, either because they want to maintain the therapeutic alliance, or they've already seen 25 patients that day, and this is their 26th, and they're just really tired. And so it's important to be able to structure these discussions about harms and benefits and tapering and discontinuation based on the tracking of pain and functionality. How many folks have seen patients who say they come in every time when their chronic pain is the same amount despite the opiate dose, and they're not functioning any better, but you said, okay, we need to discontinue or we need to taper off, and they say, but wait, the opioids are helping. Right. And so there's a disconnect there. And then lastly, close follow-up, checking prescription monitoring program and urine drug tests to make, so for example, if you're prescribing somebody oxycodone and you're checking the prescription monitoring program and all of a sudden they're picking up clonazepam at a high dose from another provider, that's a red flag. Or if some fentanyl starts showing up in their urine, you have to sort of take a step back and scratch your head a little bit. Avoiding concurrent benzos and opioids, this is because the risk of overdose death increases with the combination. And then arrange treatment for opioid use disorder if needed. And that's why we're all here, so we can treat opioid use disorder wherever we're at. All right, what can primary care teams do besides prevention to address opioid use disorder? First off, screening. Having those sort of things that you keep in mind as your red flags and asking sensitively about the criteria for opioid use disorder, and then trying to intervene early on in the case of risky use. So that person who's prescribed oxycodone and they sort of embarrassedly admit that they started buying a couple extra oxycodone pills because they like how it makes them relax after the end of the day. They don't want to run out early. That's a great place for intervention for risky use. Preventing diversion usually means close monitoring of patients, use of the prescription monitoring program, urine drug screens. You want to confirm that the substance you're prescribing is present, and you want to see the absence of other opioids or other potentially dangerous substances of abuse. What do people do in the instance where you're prescribing somebody, say, oxycodone for treatment of some chronic pain or morphine, and then there's cannabis that shows up in the urine? What do? What's the stance that you take in your individual settings?
I ask the patients to tell me about it and give them my opinion that it might not be in their best interest, but being that it's legal here, I don't really pass a large amount of judgment or change treatment based on it.
There's the California perspective there. Thanks, Scott. Yeah, no, that really depends a lot upon the legal context. Murviana, you were going to say?
I was just going to make note that it's so common in our practice that if it wasn't present, then that's the red flag.
I see.
I don't wonder if it's someone else's urine.
Well, yeah. That's a good point. Yeah. Anybody else? Laurel?
I guess I don't worry about marijuana. If I were to worry about that, I'd have an ulcer. No, honestly, I don't worry about it. It's so common in my practice, and it is not legal in the state of Ohio. At least at this point, the medical marijuana is supposedly coming around, but I don't worry about it.
Laurel, some marijuana could help with that ulcer that you have.
Yeah, I know. I'm sure it would help with lots of things.
And then what about if you see some amphetamines in the urine? The thing you're prescribing is still there, but there are amphetamines in the urine.
For me, I would look to see if well, first of all, I ask them if they've taken any over-the-counter substances before I even start.
Uh-huh.
And then, you know, because if they've taken Sudafed or something like that, that would of course show up as amphetamine.
Right.
But if they tell me no, then that would definitely be a concern for me, because meth is pretty big around here
Right.
in southeastern Ohio. So for me, that would be a dirty screen, and we would have a discussion.
I see. Yeah. What are the highest risk things, combinations that you would see on urine drug screening?
Opiates mixed with the benzos. Those are pretty.
Yep. Or if you see, like, yeah, like Casey's saying, opiates with benzos, or opioids with opioids with Z drugs like zolpidem or something like that. Yeah. Good. All right. Harm reduction is the approach. It's an approach that is humanistic, recognizing that people have choice and supporting them in trying to reduce as much harm as you can while also supporting their freedom of choice. So harm reduction in the context of opioid use disorder involves overdose prevention, provision of naloxone, infection prevention through syringe exchange, vaccination, making sure people are having clean injection techniques, and oftentimes as a temporizing measure until or before they are ready to engage in medication-assisted therapy for opioid use disorder. Now, medication treatment for opioid use disorder is highly effective in reducing relapse, overdose, other harms. Behavioral health treatments and peer support can help to prevent relapse. So the backbone of treatment for opioid use disorder is medication treatment. And then addressing comorbid conditions are also a backbone of treatment. All right, so this is our slide about reducing stigma. And stigma is kind of sneaky. It can sort of sneak into our language. A soft example of stigma that I see every day, has anybody heard the phrase, the patient has failed the medication? Yeah, right. So that's a soft example of stigma. We're saying it's kind of the patient's fault that this medicine didn't work for them, right? And then the slippery slope as it continues are sort of judgmental ways that we use to describe things. So although addiction is a brain disease, people with substance use disorders are often regarded as simply needing more willpower rather than treatment. And then language use perpetuates stigma. So, and stigma prevents people from seeking care. What are some stigmatizing forms of language you see with regard to substance use disorders?
I think that we've got some like old school clinicians who still call each other addicts and alcoholics, and sometimes that word can really put off somebody.
Yeah, the adjectives are problematic, right? So instead of addict or alcoholic, you might say what?
This patient with a substance use disorder.
Right, exactly. A person with a disorder.
Mm-hmm.
Yeah. What are some other ways that stigmatizing language can bleed into our vocabulary? How about, go ahead, Laurel.
Well, in our practice, it's interesting because there's only 3 of the 6 clinicians that will treat people with substance abuse disorders. So people that even have a primary provider in our practice, they have to see one of us in order to get treated for a substance abuse disorder. So I look at that and I think that person who's already established a relationship with this other person is told, well, now you need to see somebody else because we treat this. And maybe in some ways that's an okay thing, but in another way, I think it's, I don't know, it's just potentially.
I mean, with as common as substance use disorders are, it would be kind of like a primary care provider saying, I'm sorry, I don't treat hypertension. Right. I need you to see this hypertension person. What do you all think about the language of clean and dirty? What do you think of that language? Clean and dirty. That urine was dirty. Your urine was dirty.
No bueno.
No bueno. Right. Yeah. What do you mean my urine was dirty? What? Yeah. So how do you phrase that differently in a way that's non-stigmatizing?
Positive or negative.
Yeah. Yeah. There was this substance or this substance that we found in your urine. There was this substance or this substance we didn't find in your urine. Yeah. Yeah. It sends a message to our patients, and oftentimes we will see our own patients using stigmatizing language to describe themselves, and that is a great opportunity to help them to educate themselves about how to treat themselves with more kindness. Like if somebody comes in and they've had a lapse, and they say, they come in and they say, I really screwed up, right? Well, think about how long your lapse was this time, which was, you used for 5 days versus your last use was for 5 months. You're doing a lot better. All right,